Hi, I'm Shayla Reber, and today we're going to be talking about the Affordable Care Act versus some current health care proposals. A big part of President Obama's legacy is the Affordable Care Act, or ACA, which was effectively signed into law on March 23rd of 2010. Lathrop and Hodnicki, 2014, state the ACA was the most expansive health care reform legislation in America since Medicaid and Medicare were created in 1965. The key provisions of the ACA included strengthening preventive and primary care via insurance reform and higher reimbursement for primary care providers. The ACA also made provisions for funding provider education and offering incentives to physicians to choose primary care as their career destination. Provider funding and primary care incentives were undoubtedly attempts to alleviate the existing primary care provider shortage, in addition to the expected influx of patients the ACA would provide as a result to the increased accessibility efforts. While communities and societies in general have recently called on to the importance of preventive care, nurses have long emphasized taking a more proactive and preventive approach in healthcare. Lathrop and Hodnicki trace nursing emphasis on preventive medicine back to Florence Nightingale, as she recognized that patient care must first be focused on providing a healthy home environment via pure air, clean water, efficient drainage, cleanliness, and light. Since Nightingale's acknowledgments were first published in 1859, the nursing profession has continued emphasizing health promotion via illness prevention. One of the ways the ACA increased access to primary and preventive care was via the elimination of pre-existing condition. Watching the bipartisan meeting on health reform with President Obama and congressional leaders at the White House, it was clear that both parties agreed on this provision of eliminating pre-existing conditions on the insurance forefront as a means to increase access to care. However, there was a strong Republican pushback regarding Obama's 10 essential health benefits. Nearly every Republican leader at the meeting voiced concern about Washington defining essentials in health care. President Obama explained that the mandated essentials were meant to serve as a patient protection from insurance companies providing low-cost insurance to meet the law requirement without ever actually intending on paying claims, as some car insurance companies do. He explained that you cannot eliminate pre-existing conditions without mandating insurance policies. Some people, especially the low-risk and or younger population, wouldn't buy policies until they got sick. This, in turn, would skew the risk pool benefit and ultimately increase premiums for everyone. Therefore, although the ACA effectively eliminated pre-existing conditions to deter misuse of that provision, the ACA also requires U.S. citizens and legal residents to have a health insurance policy. The essential benefits required to be covered by all insurers include no-cost preventive benefits, ambulatory care, emergency care, hospitalization, maternity and newborn care, mental health and substance use care, prescription drugs, rehab and habilitative services, preventive and laboratory services such as contraception and cancer screenings, chronic disease management, and pediatric dental and vision care. Another provision of the ACA was the extension of dependent health care coverage. Blumenthal, Abrams, and Nuzum, 2015, state that nearly 3 million previously uninsured young Americans gained health care coverage under their parents' policies because of the ACA requirement of all private insurers and employers that offer dependent coverage to cover children until they are 26 years of age, regardless of whether they are dependent for tax purposes. This provision of the ACA affected me personally, as I was a single mother moonlighting at the hospital as a monitor tech and going to nursing school during the day. While my daughter was covered on Medicaid, prior to the enactment of the ACA, I did not have insurance coverage because, barely making over minimum wage, I could not afford to buy insurance and still put a roof over mine and my daughter's head, pay for utilities, etc. During my pregnancy, I started having gallbladder issues. I was covered under Medicaid for prenatal care, but they weren't willing to remove my gallbladder while I was carrying. Long story short, my gallbladder continued giving me problems after my postpartum period when I no longer had Medicaid coverage, so I ended up in the emergency room with acute cholecystitis at risk of gallbladder perforation, which resulted in an emergency cholecystectomy and medical bills that I'm still paying on because I was uninsured at that time. Once ACA was enacted, however, I had coverage under my father's insurance policy. By the time I turned 26, I had graduated nursing school and could afford to purchase an insurance policy through my employer for myself and my daughter, which is primarily what the extension is there for. Just enough time to help individuals who are truly trying to help themselves. Another provision of the ACA that I would like to discuss is the gradual closing of the Medicare Part D coverage gap, notoriously known as the donut hole. I'll give an example to increase understanding of what this coverage gap means to Medicare Part D recipients. My grandfather is a 68-year-old male with diabetes, hypertension, and atrial fibrillation. He has a permanent pacemaker, a knee replacement, and a laminectomy. Needless to say, he has multiple comorbidities and is on multiple prescription medications. He worked all his life offshore and his older age at the refinery plants until his health status forced his retirement at age 63. He paid into Social Security, Medicaid, and Medicare all of those years. Because of his AFib and permanent pacemaker, he is on Xarelto. He has Medicare with Part D supplemental coverage. His plan has a $500 deductible before they will pay anything towards his prescription coverage. So my grandmother explained to me that every January they pay the whole deductible up front, since his Xarelto prescription alone costs between $700 and $800. Every September, however, his Medicare Part D prescription coverage meets its cap. Therefore, the last 3 months of the year, October through December, he is responsible to pay 100% of his prescription costs in addition to his monthly premiums for Medicare and supplemental insurance. My grandmother starts requesting samples early on in the year at all of his checkups to try and save up enough Xarelto samples to cover him during those last 3 months. She says if they can't get samples, he will go without all of his medications because it would take his whole Social Security check to pay for them. So they are forced to choose between putting food on the table and having running water and electricity, or purchasing the medications that prevent him from having a stroke or exacerbations of any of his other conditions. And I feel like this is a problem that more than just my grandfather faces, several Americans. So the ACA phased in coverage in the Part D coverage gap will not eliminate all of the financial burden for him during those last 3 months, but he will be required to only pay 25% of the total cost of his medications versus being hit with the entire burden. If his Xarelto costs $800, for example, the ACA provision will make him responsible for $200 of that amount during the coverage gap. Someone that was a contributing member of society and paid into these health plans should not be forced to choose between basic necessities and prescription medications that help prevent disease exacerbations and costly hospitalizations. Now, under the Trump administration, there has been attempts to repeal and replace the ACA. While to date those attempts have been unsuccessful, certain changes have been passed. In December of 2017, for example, the Tax Cuts and Jobs Act was passed, effectively ending the ACA's individual mandate. While it is still the law to have insurance coverage, there's no tax penalty for ignoring that law. Remembering again that the penalization was meant to deter misuse of the elimination of pre-existing conditions, I'm undecided on how I feel about the lack of penalty for those that choose to ignore said law. In addition, the House of Representatives passed the American Health Care Act, or AHCA, on May 4th of 2017. Among other provisions, the AHCA permits the states to waive the 10 essential benefits provided by the AHA, effectively allowing the states to redefine what they consider essential for individual and small group markets. I feel this revision may result in decreased accessibility for Americans that fall into these insurance categories. They may be paying insurance on premiums for a policy that decides chronic disease management or emergency care services, for example, is not essential and therefore not covered. Regarding the Medicare provisions of the ACA, such as no-cost preventive benefits and phased-in coverage in the Part D coverage gap, they're not changed by the AHCA, thankfully. Another proposal currently up for debate in Congress, according to the Kaiser Family Foundation, is the Better Care Reconciliation Act, or BCRA. I chose this proposal to compare to the current policy because out of all the proposals up for debate in Congress currently, it is one that, in my opinion, attempts to fix the issues encountered by the ACA while continuing efforts to emphasize increased accessibility to care. This proposal repeals the ACA insurance mandates but retains the private market rules of extending dependent coverage to age 26 and prohibiting pre-existing conditions. To deter misuse, however, the BCRA does require waiting periods of 6 months for people who buy non-group coverage unless they've had continuous coverage throughout the prior 12-month calendar period. Another change in this proposal is the phasing out of the Medicaid expansion of the ACA and conversion instead for federal Medicaid funding to a per capita allotment. This provision also permits state option to require work as a condition of eligibility for non-elderly Medicaid adults who are not disabled or pregnant, which I absolutely agree with. Like the AHCA, no changes to Medicare benefit enhancements or provider Medicare Advantage plan payment savings exist, and it gives the state the option to waive the essential benefits outlined in the ACA. To summarize, the BCRA seems to continue the ACA efforts of increasing accessibility and affordability, but similar to the already passed AHCA, the BCRA attempts to increase flexibility at the state level. Thanks.